seen during their practice with the images and MRI and everything. With that, we have an esteemed panel of senior pain physicians who would be contributing in the panel discussion. So today, the people that are going to be around for the panel discussion, other than myself and Dr. Gautam Das, would be Dr. Eltiab Gadir from Sudan, Dr. Samajit Dev from India, Dr. TCT Novi from Indonesia, Dr. R. Gurumurthy from India, Dr. Pankaj Surange from India, Dr. Matthew Tong from Singapore, Dr. Kausar Sardar from Bangladesh, Dr. Jayashree Subramaniam from the US. So on behalf of Dardia, I would like to welcome you all for the program. First of all, my thanks and congratulations to Dr. Javed for coming forward to present 2 case scenarios by himself. So fantastic initiative, Javed. Thank you from our side for coming up and presenting 2 difficult scenarios.
Thank you so much, sir, for the opportunity.
Right. So we'll start off. So I'm going to invite Dr. Javed to start presenting the case number 1. And then once he finishes his presentation, I'm going to invite the panel to discuss the various case scenarios and how we will algorithmically and systematically find out how we'll go about in treatment of this patient. Then we'll discuss the second patient. So during the case scenario, so the whole idea is for the benefit of juniors who are joining in. So if you have any doubts during during the discussion, please put it up in the chat here, and I will try to ask this to one of the panel senior panel members, and we'll try to clarify this. So the whole idea is that we sort of have a systematic approach, and we don't miss anything. We discuss differential diagnosis and also various treatment options and what will be suitable in our scenario, that is the scenario in which you are practicing. So that's the whole idea. So can I invite Dr. Javed? Just briefly introduce yourself and start with the first case, Javed.
Yes, sir. At the outset, I'd like to thank Sir Das Sir, Karthik Babu Sir for
Javed, if I can, we can't hear you that well. You'll have to adjust your mic and maybe speak up.
Am I audible now, sir?
Slightly low volume is what I would say.
Hello?
Yeah, better now.
I'm better, sir. I'm audible now?
Yeah.
Yes, sir. Okay, sir. At the outset, I'd like to thank Das Sir, Karthik Babu Sir for giving me this opportunity. My name is Dr. Khaja Javed Khan. I'm working as a consultant pain physician at Alleviate Pain Clinic in Bangalore, India. So I would be presenting a couple of cases. These I had actually come across during my practice. Shall I start, sir?
Yes, Javed, please.
Yes, okay, sir.
You can share your screen now.
Yes, sir. I'm sharing the screen. Okay. Is the screen visible, sir?
Yes, Javed, yes, go ahead.
Okay, sir. Okay. So this is the first case. A 25-year-old male patient presented with chief complaints of pain in the left wrist since the past 8 months. History of presenting illness. The patient complained of left wrist pain towards the inner side of the wrist. Pain was dull aching type, aggravated on activity and lifting heavy objects. The patient started having pain after a history of lifting heavy weights in the gym 8 months ago. The NRS was 8 on 10. The patient had no history of tingling or numbness. The patient did not have any comorbidities like diabetes, hypertension, or coronary artery disease. Coming to the treatment history, the patient had got a local anesthetic and steroid combination injection 5 months back to his wrist which provided pain relief for 1 month, after which again the pain started again. Now coming to the examination proper, on inspection, the skin was normal. There was no wasting of muscles or any obvious deformity. There were no swelling, scars, or any ulcers. Coming to the palpation, palpation revealed significant tenderness over the ulnar aspect of the left wrist joint. There was tenderness over the left distal radio-ulnar joint. There was no local rise of temperature. The radial and ulnar pulses were felt normally. Coming to the range of motion, ulnar deviation was painful. Wrist flexion also was painful. Coming to neurological examination, sensory function, motor function, and reflexes were all within normal limits. Special tests, especially Tinel's sign was negative. Fallon's test also was negative. Now, coming to the investigations, the patient had already got done a few investigations. Uh, Initially, complete blood count, including the ESR and CRP, was normal. X-ray of the left wrist joint was done, which was totally normal. The patient had already got done an MRI of the left wrist joint, which revealed a partial tear of ulnar attachment of triangular fibrocartilage. This is the MRI report of the patient, revealing partial tear of TFCC. Now, what could be the diagnosis?
Right, Dr. Javed. So you have a young male with pain in the wrist, which is along the ulnar border of the wrist,
Yes,
and
sir.
you have basically done the basic workup with the investigations. So first thing we would like to know is there a aggravating injury which could be a sports injury, or is there a history of lifting something heavy?
Yes, sir. 8 months ago, patients was working out in the gym, and there was a history of lifting weight. The patient specifically says that he was that particular day he lifted little more than normal, and after which he felt a sudden click kind of a sensation, and the pain just started. So the pain started after a sports injury, sir.
Right. Can I invite Dr. Jayashree Subramaniam, please? Ma'am, if you're there.
Yeah, I'm here.
Good morning, ma'am. We've woken you up early, I think.
How are you? How are you?
We are good. Yes, ma'am. So young male, wrist pain, more along the medial aspect of the wrist. What would you think of?
See, I think they already thought maybe carpal tunnel, or maybe, that's why the patient got a steroid injection, still has pain. Okay. And he already gave the diagnosis where, the x-ray shows a tear of the ligament. Okay. The other differential would be, did the patient, obviously he said, didn't have any injury. There can be hairline fractures sometimes, which go undetected early. So I would have made sure that the patient didn't have a hairline fracture. What else? The other lab work, like make sure that there isn't any rheumatoid arthritis or any remote injury causing arthritis. Sometimes, that's not the usual site for a ganglion. Very rarely you can have neuromas. Those are the common ones that you deal with in that area.
Right. Thank you, ma'am. So, madam threw up a few common wrist pathologies. So, she talked about carpal tunnel syndrome. She talked about ganglions. She talked about hairline cracks in one of the carpal bones. So, these are some things that did come up. Yes. So, essentially, at this point of time, the first thing when you see this sort of patient is obviously you want to rule out a bony injury. So first thing would be to see if there is a fracture. and then take it from there, and then you will go more deeper into investigations. Obviously, the investigations would include a workup to see if there is a inflammatory response going on in terms of ESR, CRPs, and stuff. So I would like to go back to Dr. Javed and ask him, just for the benefit of the juniors, can you enumerate somebody with pain like this and there is a possibility of a systemic inflammatory response? What are the preliminary blood work that he would do in his patient?
Thank you, sir. The preliminary blood work to rule out a systemic inflammatory response, I would first like to do the investigation of acute phase reactants like ESR, CRP. I would also like to do a complete blood count along with it. And if a patient also presents with pain in the small joints as well, then I would like to do an RA factor or an anti-CCP.
Right. So what Dr. Javed said is right. So just for the benefit of the juniors, so whenever you're working up patients like this, most of the time, see the way you have to look at it is, you are a pain physician, so you are claiming that you are a specialist or a super specialist and doing practice. So even though it is not mandatory, if you go by, let's say, the NHS guidelines or something, somebody comes with pain and you do treat these patients and subsequently they go to somebody else and they find that, let's say, vitamin D is low, it does look silly. So it's always a good idea that your preliminary workup should include majority of what Dr. Javed said. So it has to involve total count, differential count, hemoglobin. You have to be doing your ESR, CRP to see if there is any inflammatory response. It may not be a bad idea that you include your BUN and creatinine because you're very likely going to be giving anti-inflammatory medication. Other than that, the common things that you need to rule out are RA factor would be a good idea, uric acid, calcium levels, vitamin D3, and vitamin B12. So the way I do it is I include most of this in my preliminary workup. So most of the time, I include a basic X-ray in the AP and lateral view, and also the blood test that I mentioned. So complete blood count, ESR, CRP, RBS, RFT, uric acid, calcium, RA factor, vitamin B12, and D3. So that would be just for the benefit of the juniors to remember. One. Did you do an X-ray, Dr. Javed?
Yes, sir. Patient already had an X-ray, sir,
Okay.
of the wrist joint, and
Okay.
it was the normal, sir. There was no obvious fracture in the wrist joint, sir.
Okay, so among the audience, I see Dr. Ravi Shankar Sharma. Ravi, are you there?
Yes, sir, I'm here.
Okay, so can I ask you something? You're not part of the panel.
Yeah, you can ask, sir, anytime, sir.
Right. So,
yes.
Preliminary assessment.
Yeah.
This before going to the MRI, we talked about X-rays and we talked about basic blood work. Assuming, let's say, it is either a tendon or a ligament injury. Let's say it's something like an acute sports injury. How would you start your treatment protocol in this patient?
Sir, basically, first, as Dr. Javed did, most of the things has been already done. Apart from this ultrasonographic examination of the tendons that are getting inserted over this carpal and metatarpal area. So especially I'm worried about this after the steroid injections, the ligament like flexor carpi ulnaris, that might be damaged. Or second component you may think of, sir, Guyon's canal syndrome. That might be entrapment of ulnar nerve. It may be the things that has been missed out in this diagnosis.
Okay, so Ravi, can I ask you, are you familiar or do you follow what we guys call as a RICE protocol or the PRICE protocol? Are you familiar with that and do you follow it?
Sir, I have heard about this, but particularly not following this protocol, sir. Yes, sir.
Any of the juniors would like to enlighten the audience about what is a RISE protocol or a PRICE protocol? Dr. Javed or Dr. Ravi, or I see Dr. Jeshnu here. Any of the juniors would like to come up and tell us?
Yes, sir. Jeshnu, yes, sir.
Yes, Jeshnu, go ahead.
Sir, yeah, right protocol I routinely follow for acute injuries, sir, like rest, ice compression, elevation of the limb, of the elevation of the affected limb. But as Javed described, it's an old injury, so I feel RICE may not be very helpful in this particular case.
Yeah, so essentially I'm asking, in a situation where you had seen this patient before the steroid shot, if you had seen him first, that's what I'm asking you.
Yes, sir. In acute case, I would have been followed this thing with analgesic also, sir, NSAID also.
Okay, so one of the things that you would like to, just for the sake of the juniors, one of the things that you can do in an acute injury, especially a sports injury, is, like Madam has put up in the chat box, it's called the RICE protocol. RICE stands for rest, icing, compression, and elevation. And so you'll find that a significant number of patients settle down very well with rest, icing, compression, and elevation. A lot of times what happens is you find that they have partial thickness ligament injuries and partial thickness, what we call as strains and sprains. So for strains and sprains, the rest, icing, compression, and elevation of the affected limb works amazingly well. Along with that, you have an opportunity to either give NSAID or a COX-2 inhibitor and wait and watch for some time. And in sportsmen, you have the pressure of treating these patients very fast, but in a normal individual, you can do this and wait for a couple of weeks and see before you proceed, right? So if it is a RICE protocol, it's rest, icing, compression, and elevation. There is also one called PRICE, PRICE, that is protection, rest, icing, compression, and elevation. And obviously, when I say compression, it may involve a brace, like a wrist brace. And also, if you know that if the thumb is involved, you also have a wrist which with a thumb splint. So bracing and splinting for different parts we have. We have braces for tennis elbows. We have braces for wrist. We have braces for wrist with thumb. Obviously, we have ankle binders. We have knee braces. So depending on what is involved, you give the appropriate brace. Can I go back to Dr. Das here and ask him, how would he involve neurological involvement in a patient with this sort of history? Dr. Das, please.
The most important part is the clinical, the examinations. In that, already Dr. Javed has mentioned from the history itself. If there is a neurological injury, then there will be certain features which is matching with the neurological injury. That means there might be some, the numbness, there might be some paresthesia, hyperesthesia. All these will be coming from the history. And during the examinations, we might be getting some numbness, we might be getting some motor weakness. So these are the things which is associated with the particularly the acute injury. So the clinical evaluation
can I ask everybody to be on mute, please?
Okay, Karthik, I'm muting all, and please unmute yourself.
Right. Please go on, sir.
Okay. Okay. So what I was telling, that clinical evaluation is important, and those should be coming from the history as well as the clinical examinations. And if needed in some situations, definitely we can take the help of the nerve conduction studies also can be taken.
Okay. So essentially what sir is saying is you have to look for sensory deficits or motor deficits. And if you are still not sure, there is a role for doing nerve conduction study or EMG, that sort of thing. Javed, I would like to go back to Javed and ask him, is there a possibility that there is a problem in the cervical spine and the pain is radiating and it is presenting with pain in the wrist? Is that possible? And has he ruled out any cervical spine pathologies in this case?
Sir, yes, sir. Sometimes cervical spine, any cervical spine problems, especially which are impinging over the cervical nerve roots, like C7, can present sometimes with pain, but many a times there will be an associated neck pain, which will be radiating towards the ulnar part all over the arm, shoulders, and radiating more towards the ulnar part of the hand, sir. And since the patient presented with an isolated pain over the wrist joint, especially the ulnar portion, then with that, I ruled out the cervical pathologies.
Right, Javed. So we are from the history and clinical examination, it does not look like any neurological things are involved. So people talked about ulnar nerve compression. We also talked about cervical radiculopathy. So if we are suspecting this, obviously we will do the more corroborative studies like EMG and NCB. Let me go back to Dr. Jayashree and ask her, in terms of sports injuries, does she see patients, let's say, with, let's say, tennis players or badminton players who come with this sort of profile?
I actually haven't seen that many, like players with this type of injury. Sometimes, like in a pain clinic, these things come and go. Sometimes you will get young patients with some vague wrist pain. Usually what I see is patients who have had carpal tunnel surgery and their symptoms have not resolved. That's the commonest one. And other than that, what I see commonly would be like patients who have had a fracture. What comes to mind is hairline fracture in the radius in the wrist, where the patient had a cast for about almost 3 months. The cast was removed, swelling, redness, typical CRPS symptoms, but very isolated to the thumb. And these days, we have to remember, if you think it is an entrapment of a local nerve, we have the luxury of having an ultrasound. So all that I did for the lady, because the movement was very restricted, traced the radial nerve a little higher and did a block, and she was able to get her mobility back. So commonly it is post-fracture where the patient has been in a cast, and you may get symptoms of either nerve entrapment, mostly CRPS, or you do get to see patients who have had like a carpal tunnel surgery. Those are the common ones that I see.
Right. So as we go along, we are picking up more and more differential diagnosis. So earlier we talked about carpal tunnels, we talked about wrist ganglions, we talked about nerve entrapment. Madam is saying yes, it's possible with sports injuries. It's possible with patients previously.
Karthik, another diagnosis, is the ulnar styloiditis. Again, that can be a differential diagnosis. Ulnar styloiditis, which can be, the inflammations of the soft tissues there at the tip of this ulna.
Yes. So ulnar styloiditis is possible. Ulnar styloid process fracture is also possible. So because we do find these are avulsion injuries. So these tendons are attached to the tip of the bone, and because the tendon is pulled forcibly, the part of the bone gets avulsed. So that too we do see that.
Another thing that I forgot to add was, I have seen varying severities of rheumatoid arthritis. So, in a really bad case of rheumatoid arthritis where, all the fingers, all the joints are totally, in the early stages, you might see nodules, you might see swelling. It's very hard to make out in a bad case what is what, okay? But sometimes, if it is late stages, you might find that the entire wrist is fused. So that I have seen. I forgot to add that.
Right. Okay, so we did, Javed did go ahead with the, by the time this patient did come, the patient has been tried on conservative management, which probably included NSAIDs or COX-2 inhibitors, and the conservative management we talked about. The patient did not become better, and somebody has apparently tried a steroid, local with steroid injection, which gave a periodic, for a short duration of time, there was a relief, yes. So having said that, somebody like this young patient who is not responding to conservative management with MRI findings suggestive of a tear in the TFCC, how would you go about it? Can I ask Dr. Das, sir, please?
So first of all, what Dr. Joyce told, I'll be also agreeing with the same. Normally, this kind of sports injury patients we are dealing very less. And but one of the very the unique thing in this patient is having a chronic pain for the longer time. So that might be the very important reason why this patient has visited a pain clinic. So obviously, this kind of ligaments and the tendons injuries, the automatic choice nowadays in the present day scenarios is the platelet-rich plasma regeneration therapy. Another options which can be we can think is your prolotherapy. Prolotherapy is, there are a lot of different combinations of the prolotherapy. One of the very important prolotherapy is your dextrose. Sometimes we are mixing the dextrose and the ozone. So this can be also a good choice. So prolotherapy and the PR platelet-rich plasma therapy or any other form of the regeneration therapy should be the choice, to have to try to the healing influencing the healing process of this injury.
Okay. So I do see a bit of patients with sports injuries, and we do see this sort of, because I work with the ortho team very closely, I do see this sort of injuries quite commonly. Probably if Javed was spent a bit of time in my clinic, so it's possible that he has also seen one or two of these patients. So majority of the time, this sort of injury happens when you do a movement where you are putting more pressure on the ulnar aspect of the wrist. So it is possible when you are, like, let's say playing a tennis shot, like a forehand, and you're trying to get a top spin, like when you're trying to hit over the ball, that is possible. This sort of injuries we also see in badminton players, so that's also possible. Again, it is possible if you're lifting something heavy like a dumbbell, and also if you're falling with what we call as an outstretched hand. Now, triangular fibrocartilage complex, which is the full form of TFCC, is a set of ligaments that are there in the inner aspect of your wrist here, right? Now, it is made up of essentially about 2 or 3 of these ligaments. One of them is the ulnar collateral ligament of the wrist. Remember that there is an ulnar collateral ligament of the wrist, there is an ulnar collateral ligament of the thumb, there is an ulnar collateral ligament of the elbow. So there are 3 types of ulnar collateral ligaments. So what I'm talking about is the ulnar collateral ligament of the wrist. There is also a fibrocartilaginous discus, which is more like a soft tissue pad. Essentially, we are talking about an area between the radius and the ulna and the carpal bones. And finally, the last component is the radioulnar ligament. So we're talking about 3 sets of ligaments which are very close, and they are together called the TFCC, which is the triangular fibrocartilage complex. Triangular because the initial discus I talked about is triangular. Now, obviously you have to rule out other pathologies which involve the carpal bones. You also have to make sure the styloid processes, avulsion fractures, they are not there. One. Second is obviously the confirmation is by doing a MRI. Once you have done the confirmation, the conservative management we talked about already: protection, rest, icing, compression, and elevation, and anti-inflammatory medication. So usually the way I do it is rest, icing, wrist splint, anti-inflammation, and elevation. If they come around with this, then we are okay. In between, we can have, like Dr. Jayashree talked about, immobilization itself can cause some problems. It can cause muscle wasting. In very rare cases, it can cause things like CRPS. Then if they don't come around with that, probably a better way of doing it is, instead of doing a steroid shot, which essentially can damage these nerves and make them more prone to tears. These are very, very thin ligaments. So this sort of ligaments is not a great idea that you do a steroid shot, because essentially when you do a steroid shot, you are essentially suppressing the inflammation and suppressing the symptoms. They have to heal by themselves, and this can take a period of time. So the regenerative therapy, like Dr. Das was saying, the PRP comes in there in hastening the healing process that can happen. So probably the conservative management followed, if they don't come around with that, a PRP would be a better option in this sort of profile. And again, if you're still not sure, in my centers, because I sort of do a reasonable amount of sports medicine, we also don't hesitate to do a wrist arthroscopy. So we can sometimes do a diagnostic arthroscopy and go in and see what's happening. So that's the thing that is optional, but probably it may not be possible in every center. That is again an option, right? So can I call in, I just saw Dr. Kausar Sardar from Bangladesh. So can I call him and ask him, somebody with TFCC injury in the wrist, what would be his first, if conservative management fails, what would be his first choice in terms of treatment? Dr. Kausar, please.
Okay, thank you, Karthik. Sorry, I joined later part of the. I have missed the whole the presentation, but by this time I'm just saying what the Gautam Das sir sent by WhatsApp, the whole presentation. Just what I have seen. Okay, this is over actually. So, what point you want to know after conjunction?
Okay, Dr. Kausar, we'll call you in for the next one. No problem. Thank you very much. I'll get you in the next discussion. Thank you. So, in terms of treatment, can I call in Dr. Jayashree and ask her, in terms of treatment, considering that the TFCC injury is documented in MRI, other than conservative management and other than regenerative therapy, is there any other option, ma'am?
Any other?
Dr. Kausar, can I get back to you for some time? Can I please get back to you? Dr. Jayashree, can I ask you if there is any other option other than conservative management and PRP?
First thing, what I was going to say, Karthik, is, you probably work with a great group of orthopods, but before the patients come here, orthopods here, 90% of them, first thing they will do, they will have a physician assistant or somebody seeing the patient. First thing they will do is a steroid injection, that too a blind steroid injection. Okay, so the damage, whatever you said, is already done. Okay, and other than saying that do PRP.
Jayashree, can I interrupt you? So are you talking about even in the acute case also?
Yes.
Okay. But I feel, yes, right.
And sometimes, what's even worse? No diagnosis, patient says pain. The patient wouldn't even know. This is very frustrating, especially in the elderly with chronic pain. They don't remember anything. Then you will dig and find out they went with shoulder pain here, knee pain there. They've had 4 steroid injections in a matter of a week, and they don't even know what these people are being given. Yeah, it happens. It's not a thing. And then sometimes you have to, I see this every week, that patients come with knee pain, either before or after knee replacement. And then you ask them, and then they say, oh, the injections don't work. So you dig back, you see that the orthopod with his office note had put a 2-line note where he says they prep the area, and they put 80 milligrams of triamcinolone. Okay, not even 40 or anything, just 80 milligrams blind into the knee. Now, how are you going to convince this patient that you will do something different? It's very hard. Okay. So the only thing I would add is if it is a young patient, there is a strain in the ligament, patient already has had a steroid injection, I would have had a neurologist evaluate and get an EMG. You can argue either way, like what is the EMG going to show? You know, majority of the time it is inconclusive. The only thing is before you do more damage, you at least are armed with all the knowledge as to what is going on before you say, okay, I will do PRP or I will do something else. But usually these patients, other than rice that we already discussed about, the only other thing I would add is, see, don't forget the patches, okay? Localized pain, instead of making patients swallow, you can use lidocaine patch, you can use diclofenac sodium patch. Don't forget the patches. So in accessible areas like the knees, like the wrist, have them use it. At least temporarily, it will give you the relief. Second thing, see what you can achieve with a needle putting a drop of lidocaine. If the patient used a 4% or 5% patch, teach them that, hey, cover your wrist, that area, keep it on for 12 hours or wrap it up properly, use it consecutively for 7 to 10 days. Enough of it would have been absorbed. So if it is sympathetically mediated or if it is a nerve entrapment, you at least will have an idea before you get more invasive. Those are the two things that come to mind. Other than that, what else can you do? Like he was saying, yeah, you can have them have an arthroscopy if you have a surgeon that you are very familiar with.
Right. Okay. So essentially, we don't have too many options. Yes, but yeah, it is possible that if this doesn't work, there is the fallback step is probably arthroscopic repair. So is there anything else any of the panelists would like to add to the discussion, or can I sum it up? Any of the other panelists? I saw Dr. Novi join up. Is Dr. Novi with us?
Hello.
How are you?
I'm fine. We are having a meeting, a tiny annual meeting, online, of course. Sorry for being late. Yeah, I'm here. I just joined, but I know the case. I've read it. I agree with you all that it is TFCC. TFCC is a kind of not fracture, not tear, but yeah, injury to the triangular fibrocartilage complex. So means that for me, I will not give steroid inside, but the presenter has already given the patient PRP. That's good, and the pain relief is 80%. I usually repeat the PRP 3 times in 1 month interval. But by the meantime, I usually ask the patient to immobilize the injured part so that the healing process will be sooner. Usually it takes time about 12 weeks. Of course, by 1 month or 6 weeks time, we must give the patient some load to the ulnar wrist part of the wrist. So then the healing will be faster.
Hello.
Go on, Dr. Novi.
Yeah. So there's a timeline to do rehab while we immobilize the wrist. So not in 3 months we must immobilize the wrist, but should follow the healing process.
Right. Okay. Thank you, Dr. Novi.
Welcome.
Okay, Karthik.
Yes.
Hello, Karthik.
Yeah. Yes, sir.
Yes. There was one question that whether there is any role of any antidepressants there. Question came in the chat box. I saw this. So, what I feel is any chronic pain, there will be some changes in the the sensitization kind of thing will be there. So, because this patient is having the 8 months this thing. So, in my opinion, so here along with the PRP injections, the antidepressants, low dose antidepressants should be definitely having some role.
Right. Okay. So I saw Dr. Guru joining up. Dr. Guru, are you with us?
Yes, sir, I am there.
Yeah. I'm going to ask you a familiar question. Ultrasound examination of the wrist.
Okay.
How would you diagnose?
Literally speaking, I don't have that much experience with this cartilage. So
Okay.
I am not in the position to explain. So actually this case appears to be totally new for me.
Right. Okay. So yeah, if Dr.
I
Guru is
can
not taking, if
Dr. Karthik,
yeah,
I can explain. In the
yes.
ultrasound, we put the probe long axisly in the sixth compartment of the wrist extensor, means at the ulnar side of the distal ulnar styloid, where the extensor carpi ulnaris is.
Correct.
Okay, firstly, we put the probe short axisly over there, and then once we see the extensor carpi ulnaris, we rotate the probe 90 degrees till we found the extensor carpi ulnaris in long axis view. Then just below the HU, the extensor carpi ulnaris, there will be a gap, which is the joint between the ulnar styloid with the carpal bones. And down under, we will see other joints, which are the carpal bones and the radio ulnar joint below. There will be a fusion there compared to the non-injured part, non-injured hand. And if we turn on color, we may see also hypervascularization, means bluish and reddish of the screen, means that it is inflamed. But not always we will see the inflammation. At least we will see the hypoechoic sign, more hypoechoic than the normal side.
Right. Okay. So essentially, one of the things that you can do is like what Dr. Novi said, trace it along the ulnar aspect of the forearm. The sixth compartment is a good idea. Other thing is always one of the clues that you want to do whenever you're doing a procedure like this is ask the patient. So make sure the patient is telling you which is their most tender point. It may not be a bad idea to mark it before you start prepping this patient, before you start putting your betadine or sterlium. And if you have identified the most tender point, it sort of gives you a clue as to which is your exact location, and you can take it from there. One. So always remember before doing the injection for any tendon, especially if you're doing a PRP injection or a steroid shot, the location, map it before you start the procedure. Maybe you can mark it with a marker or pen. One. Second is there was a doubt in terms of what PRP, how often you do it. So whenever you do a PRP injection, you have an option of using a commercially available kit, or you can use your own kits and then do it. Obviously, the quality of PRP is going to change depending on what sort of kit you're using, how much blood you're going to take, how much volume you're going to inject, and how accurately you inject, and that sort of thing. So I have done probably about 10 TFCC PRP injections. Like I told you, I do a reasonable amount of sports injuries, and my results have been very good. You get amazing results, and most of my injections are just single shot injections because we identify and do the injection properly. And I always use a commercially available kit, not a probably my own kids. So probably I'm assuming the quality of PRP is better. If there is a role for doing repeat PRP injections, like Dr. Novi was saying, you can repeat it at a duration of, let's say, 3 weeks to 4 weeks. So you can repeat 3 shots. That's an option. Also, after doing the first injection, you sort of assess it. So what we do is we sort of assess these patients in terms of wrist mobility and how much pain is there. So immediately we do the injection. Obviously, this patient is stopped on NSAIDs or COX-2 inhibitors about, let's say, 7 days to 5 days before the injection. Once we do the injection, the only painkillers that we give are weak opioids like tramadol and obviously paracetamol. You have an option of icing because it's going to be a bit sore, and you also have an option of putting a wrist splint. So wrist splint, icing, paracetamol, tramadol. So this is the way you have to manage the post-operative period. And also make sure they actually don't move too much. Whenever you do a PRP injection for a period of at least 4 to 5 days, because you don't want the PRP. Basically, you're expecting the PRP to, if you look at any tendonitis or partial tears, if you look at tendonitis at the microscopic level, they are actually microfractures. So when you actually do a steroid shot, the microfractures are going to be there. You're essentially reducing the pain and the inflammation. But if you do reduce the inflammation, you also know that at the back of the mind, the healing takes a little longer. If you do a PRP injection, you are essentially hastening the recovery process because it's going to stick like a glue. Theoretically, it's going to stick like a glue along the microfracture. So that's what you are trying to achieve with the PRP injection. So it's essential that you immobilize for a period of at least 5 days to 7 days and then see and reassess. So usually in my practice, I reassess after a period of about 3 weeks, and most of these patients are pretty much okay. I very rarely repeat PRP shots, but again, it's possible that you have a protocol where you repeat these shots once in 3 weeks, so that's fine. So that's the way you go about it. In terms of volume, this is a very small ligament, so anything about 1.5 to 2 ml would be more than enough to inject into or around the ligament. General principle, if you're injecting, just for the sake of the juniors, if you're injecting around a tendon or something is, if you're injecting with a steroid, whenever you're injecting tendon, inject around the tendon. If you're injecting PRP, inject into the tendon. So that's the general principle. Other than that, it's a fairly straightforward condition. And I have to say, in my practice, I must have seen in the last 1.5 to 2 years, about 20 cases. And in those, about 10 of them, I must have done PRP. Results are very good. And most of the time, these are sportsmen who want to, not like serious sportsmen, but amateurs. And we also get a fair share of cricket and serious players also. So they've all gone back and started playing immediately. Only thing is you have to decide on what sort of treatment depending on how much time the sportsmen have. That's the only thing that you want to keep in mind. Right? Any of the other panelists would like to contribute to anything else? Or
if you can go over, I think, you covered it very well. Only thing that I would add here is if you can tell the juniors or the people who don't do PRP commonly, like, what medications to avoid before and after.
Right. So obviously, you have to prepare these patients. So essentially, see, the PRP or regenerative medicine itself evolved from sports medicine. So you had a set of the normal patients who came in, who you can actually say you take rest for 2 or 3 months, it will become all right. It will become all right. But the thing is, in sports medicine, they don't have 2 or 3 months to wait it out. So that's why PRP came, to hasten recovery, to make these patients go back to action fast. So we started doing it in sportsmen. We found good results. So we brought it to the general population. So that's how we got PRP and BMAC and stuff. So in terms of regenerative medicine, probably my way of doing this is not a condition where you should do steroid. You should probably go for PRP or BMAC straight away. PRP is more than enough, in my opinion, for a TFCC injury. So essentially, after you confirm the diagnosis, you have to stop NSAIDs and COX-2 inhibitors. So in my practice, I stop it for a period of about 5 to 7 days. If these patients are on antiplatelet medication, that's a different story. So you have to consult with the cardiologist and then stop it. But again, my way of doing it is, this is essentially a regenerative treatment, is essentially for young patients, sportsmen, that sort of thing. If you're going to see a patient who's actually on antiplatelet, who's some 60, 70-year-old, he's not your ideal candidate for PRP. So NSAIDs, COX-2 inhibitors, you have to stop for a period of 5 to 7 days. Antiplatelet medication, depending on protocol, after consulting with the cardiologist if that's required. So those things you have to stop. And also remember, compared to a steroid shot, the PRP shot, they will have pain at the time of injection and post injection, unlike a steroid shot where they improve dramatically. So you have to be ready for that. Your patient has to be ready for that, because some of these patients will not appreciate this sort of pain, knowing that you cannot give NSAIDs or COX-2 inhibitors in the immediate post-injection period. And so after we do the injection itself, the only options that you have are paracetamol, weak opioids like tramadol or tapentadol. Obviously, icing will help and immobilization will help. So the drugs essentially that you should stop are antiplatelet medication, NSAIDs, COX-2 inhibitors, steroids. So if you have done a steroid shot, I think you should wait for at least 2 or 3 weeks before you think of a PRP shot. So all these medicines, common medicines, you should stop before doing the PRP itself. Yes. Anything else the panelists would like to contribute here?
Karthik, I just wanted to say that, see, because of the acidic pH, sometimes, when you do like Hylagan injection, you can mix local anesthetic with the Hylagan, or you can inject the knee joint with local anesthetic and then inject it. But with PRP, because of the acidic pH, you cannot combine a whole bunch of, you cannot combine any local anesthetic, because that will alter your PRP. So that's another reason why the injection is painful and you need to tell your patient beforehand.
Yes, yeah, you are right. You cannot combine PRP and steroid, definitely, that's given. And obviously, you cannot inject too much of local anesthetic at the place where you are going to be injecting PRP. So maybe local anesthetic at the level of the skin, and then you have to go inside and inject the PRP. It will alter the pH, right? She's right. Right, if there is nothing else from the panelists, let me sum up the case. So this is a young patient with the wrist pain along the ulnar aspect. So the differential diagnosis the panelists discussed about are fractures involving the carpal bones, fractures involving the styloid process of the ulna and the radius. We talked about nerve entrapment. We talked about ulnar nerve entrapment. We talked about median nerve entrapment. We talked about radial nerve entrapment. We talked about ganglions. We talked about carpal tunnels. We talked about conditions like CRPS, failed carpal tunnel surgery. So we discussed about all of this. And obviously the diagnosis is confirmed by MRI. So conservative management, we talked about things like rest, protection, icing, compression, and elevation, mild dose of anti-inflammatory. If they don't settle, there is a controversial role for steroids. A better option would be to think of patients who don't respond to conservative management. Better option would be to think of PRP injections under ultrasound guidance, under sterile precautions, followed by the injection with wrist splints, icing, elevation, and supplements. You obviously have to stop NSAIDs and steroids post-injection. And then once they come around, rehabilitation after about 3 or 4 weeks when you think the injury is reasonably healed. So that's the way to go about in a TFCC injury, right? So if there is nothing else to add, can I invite Javed to go on to the next case scenario? Can I?
Yes, sir.
Yes, Javed, can you go ahead with the next case scenario?
Yes.
Somebody has asked, should we stop statins for PRP injections? Can I ask Dr. Das, is there any specific indications to stop statins for PRP?
I don't have any idea about it.
Don't think statins should interfere with PRP.
I don't, probably not, you know, I told you, probably not. The drugs, whatever you have discussed, antiplatelet therapy and the anti-inflammatory drugs and the steroids, they are the most important drugs which should be avoided. Statins, I don't have any idea. Probably statins are not, you know, statins can be, you know, allowed. Statins probably don't have any interference with the PRP.
Right. And also there is a doubt on surgical intervention. Yes, there are lots of surgeries for TFCC reconstruction. Some of these surgeries are open. Some of these surgeries are arthroscopic. Lots of surgical options are there. In fact, the surgical options are the main options. The PRPs actually plays a very small role in management of TFC. But those are for very serious complete tears. Dr. Javed.
Yes, sir. I'm ready, sir.
Yeah, share your screen, please.
Sure.
Okay, Karthik, this is a little bit more common case. I told Javed that, okay, we can have some common cases also, particularly those who are juniors. You know, some of the common cases also very important for them.
Yes, sir.
Shall I start, sir?
Yes, Javed, go ahead.
Okay, this is the second case which I came across. This was about 2 months ago. A 51-year-old female patient presented with chief complaints of pain in left side of the face since the past 8 years. History of present illness. The patient complained of pain over the left side of the face in the lower jaw. Pain was shooting, electric shock-like, stabbing type. The patient used to get multiple attacks in a day, almost 8 to 10, each lasting on an average of 2 to 3 hours, sometimes even 4 to 5 hours, with a pain-free interval in between. Pain was severe in intensity, aggravated with triggering factors like eating, talking, or washing her face. The patient felt slightly better after taking a nap and her medications. History of tooth extractions, the molar teeth of the lower and the upper jaw 7 years ago. There was no history of pain near the eye or the upper cheek region, no history of redness of the eye or watering of the eye, no history of swelling of the eyelids, no history of nasal discharge or any nasal congestion. The NRS was 10 on 10. The patient is a known hypertensive on tablet nebivolol 2.5 milligram once in the morning OD. The patient has had suicidal thoughts and depression due to the excruciating pain and is on a combination of flupentixol and melitrazine once in the night for her depression. Now, treatment history, the patient is on tablet carbamazepine, oxcarbazepine 450 in the morning, 450 in the afternoon, and 600 milligrams at night. Tablet gabapentin 400 milligrams in the morning, 400 after lunch, and 300 milligrams at night. Tablet pregabalin 100 mg TID. The patient had undergone a maxillary mandibular and mental nerve block with local anesthetic like lignocaine and methylprednisolone at a local clinic under as a blind block, and the patient had more than 80% of pain relief. This pain relief lasted for 2 to 3 weeks, and then the patient again started having the same excruciating pain. Now, coming to the examination proper, on inspection, the skin was normal. There was no wasting of muscles or any obvious deformity, no swelling, scars, or ulcers. Palpation was normal, range of motion was normal. Coming to neurological examination, cranial nerve examination, the first nerve was normal smell sensation. The second cranial nerve, Pupil size, shape, symmetry was normal. Visual acuity was normal. Third, fourth, and sixth cranial nerve, ocular movements were normal. Pupillary light reflex was normal. Fifth cranial nerve, there was allodynia present over the lower jaw region. The forehead and cheek sensations were normal. Muscles of mastication had adequate motor power. Corneal reflex was normal and jaw jerk also was normal. The seventh cranial nerve, facial movements were normal. Eighth cranial nerve, hearing was normal. 9 and 10, gag reflex was normal. 11th cranial nerve, shrugging of shoulders, turning of head from one side to the other was normal. And the 12th cranial nerve, tongue movements were normal. Coming to the investigations, complete blood count was done, which was perfectly within normal limits. MRI scan of the brain was done, which was also totally normal. Now, the diagnosis.
So first, congratulations, Javed, for a very thorough examination of all the cranial nerves.
Thank you.
Thank you.
Is it a straightforward V3 we are seeing, or is it?
Yes.
Right. Can I invite Dr. Guru to assess this case scenario? This pain pattern, what would he think of? What are his differential diagnosis? Dr. Gurumurthy, please. Dr. Guru, you're there? Dr. Matthew Tong, can you hear us? You have to unmute yourself, Dr. Matthew.
Hello.
Yes, sir, we can hear you. Go ahead.
Yeah. Mandibular division of the trigeminal nerve, trigeminal neuralgia is the commonest among the three divisions, it is said. As you mentioned, the history is very, very typical of the neuralgic pain. For us, I think the MRI, as you said, was normal. But in the MRI, we need to look out for secondary causes of trigeminal neuralgia. For example, middle cranial fossa tumors. Then, of course, you want to think of more esoteric possibilities, things like a woman might be taking osteoporosis medicine. Some people get osteonecrosis, and that is something that one has to think about. And before you start carbamazepine, usually we want to do some genetic testing, the HLA status. Because I myself, even in the limited amount of carbamazepine I gave, I have experienced one case of allergy. Terrible, very, very bad. Other than that, I suppose the history is pretty typical, right? I can't think of anything else to add. Thank you.
Thank you, Dr. Matthew. Can I invite Dr. Kausar here? Dr. Kausar, if you're there. Okay, so can I put this question to Dr. Das itself, sir? Can this be cluster headache? If so, what would be the clinical differentiating features between this presentation and cluster headache?
So here almost there is no confusion with the trigeminal neuralgia because the jaw is involved, third division is involved. But sometimes the cluster headache comes in a differential diagnosis of the trigeminal neuralgia when the first division is involved, or sometimes it might be the second division is involved. Because one of the very typical findings of the cluster headache is the periorbital, the headache. So the pain around the eye is one of the very important feature of the cluster headache. So in that situation, the trigeminal neuralgia and the cluster headache might be confusing in some cases because both the situations the pain comes in episodes. It lasts for some time, some minutes, or sometimes typically at the beginning trigeminal neuralgia lasts seconds to minutes. But gradually, when the disease progresses, it can be even hours. Like in this patient, the patient was having the attacks of the over the hours. So at the same time, similarly, the cluster headache also having the very severe pain. Sometimes it's called the piercing pain. Lasting for around half an hour or something like that. And in between the attacks, completely there is no pain at all. Another important thing of the cluster headache is the pain comes in like an alarm clock, like in a certain period of time. Sometimes patient will be telling that at night at 2 a.m. my headache starts, and I'll be it will be awakening me from the sleep. So normally in the other situations, like here in this patient was having telling that okay, when the sleep patient is pain is little bit less, but cluster headache might be the awakening the patients from the headache. But most important of all the cluster headache features is the autonomic response. That means the patient will be having some of the autonomic, like tearing, the conjunctival congestions, the running of the nose, the choking of the nose. So these will be, and it will be strictly unilateral in one side. So these are the features which is normally differentiating with this autonomic features, the cluster headache with the trigeminal neuralgia. But here the trigeminal cluster headache is not important because the pain is not around the eye.
Right. Thank you, sir. Can I invite Dr. Jayashree and ask her, could this be a orofacial pain? Could this be something coming from the TM joint? Could this be something that's coming from the teeth?
Sometimes, you can have this type of symptoms very similar to trigeminal neuralgia after tooth extraction. So sometimes, patients have molar tooths where they have to dissect out the bone and do this resection. So you can have this type of symptoms presenting after a major tooth extraction. So what I would say is it's good to have the gum and the teeth examined. I think he presented it very well. He went over all the symptoms. But yes, TMJ causing only this isolated area of pain is rare. But the referred pain from TM joint, if it is minor, then it could be in the same area, but the patient will have more facial muscle spasm and also headaches. Typically, TMJ patients will complain of pain when they wake up or by the end of the day. Either, they grind their teeth or they also have a jaw grinding, which is the main reason for their headaches. And it's typically one-sided, like your current presentation. But I think they don't have so much radiating pain just along an isolated nerve. And really bad TMJs where they can't even open the mouth, the diagnosis is very obvious. You don't get so much of radiating pain along the nerve. That's what I have seen.
Right. Any of the other panelists would like to contribute in terms of any other differential diagnosis? Anybody thinks it's coming from the neck? Anybody thinks it's glossopharyngeal, Eagle syndrome, referred pain? Any of the other panelists would like to?
Eagle syndrome, typically, they will complain of difficulty with swallowing. You won't get the radiating pain just along the jaw in Eagle syndrome. That's number one.
Karthik, atypical facial pain can be one of the differential diagnoses. But again, here the distribution of the pain is one of the very important clue which will not be there in the atypical facial pain. Atypical facial pain is basically a diagnosis of the exclusion when we are unable to fit with any particular diagnosis. So that is one of the very important areas. And the distribution of the pain is not typical. Nature and the character of the pain is not neuropathic, like here what he described here nicely. So, but definitely the atypical facial pain should also come in a differential diagnosis.
Right. So just for the sake of the juniors, do remember that just because as pain physicians we do the trigeminal block, don't keep thinking of only about the trigeminal neuralgia. There are lots and lots of oral pathologies, atypical facial pains, muscle spasms, trigger points in the face, all sorts of things are there. So don't jump and do injections in a lot of patients because you have to be very clear in terms of diagnosis, especially in a situation like trigeminal where there is no one confirmatory radiological or blood test. So this sort of situations, you have to be very clear in terms of diagnosis, confirm the diagnosis before you proceed with the medication or the intervention. Also, just for the sake of the juniors, I would also emphasize that in a situation like this, if there is a doubt in terms of diagnosis, never hesitate to take help of your neurology colleague or neurosurgeon colleague, because you don't want to end up doing intervention in a patient who is typically not your patient to do an intervention. So just do keep this in mind. So in terms of trigeminal, which the panelist seems to agree is the most likely diagnosis, can I ask one of the panelists if the MRI is mandatory, and if so, what exactly are they finding out from the MRI and what are they ruling out from the MRI? Dr. Kausar, if you're there. Dr. Kausar is there? Okay, can I come back to Dr. Das and ask him, in terms of trigeminal MRI, what to expect? What are you ruling out?
So the most important part to rule is the two important aspects. One is, first of all, what to order. What Dr. Matthew Tung was telling, that sometimes whenever we are asking the MRI in these situations, it is not necessarily that you need to go for the MRI angiogram, but you should be advising it the trigeminal protocol, the MRI trigeminal protocol. We have to mention it in the bracket, that the MRI of brain trigeminal protocol. So, but if there is any confusion, even we can go for the MRI angiogram. And two things we are looking for. One is your secondary causes, if there are any SOL or any other things. And second thing is whether the cerebral artery is impinging the nerve. So the other two important things which you should look for, because that is going to change our management areas. But I'll be asking Dr. Matthew Tung's also opinion regarding these things, regarding the MRI, what we should do for the in a trigeminal or this kind of patient.
Dr. Matthew Tong, can you enlighten us more about MRI findings in patients suspected with trigeminal neuralgia?
Yeah. Oh, yeah. In the trigeminal, like I said, I think one of the most dramatic one would be tumors involving the middle cranial fossa, around the floor of the middle cranial fossa, where the gastrin ganglion is situated. A meningioma, a schwannoma of the trigeminal nerve, which can either be there or even more in the posterior fossa. Then we go on to the posterior fossa situation. We look for vessels around the fifth nerve. And for looking at the vessels, I wrote down in the chat that the sequence that the radiologist wants to know would be the MRI CISS sequence. And there you can see how the vessel loops around the root entry zone of the trigeminal nerve. Yeah. Some of them can be quite scary. And then, of course, we look in the parenchyma of the brainstem to see if there, of course, just now when I looked at the examination, it was very good that he has ruled out all the other cranial nerves, because one of the differentials is some of the demyelinating diseases. So demyelinating diseases can, although I'm not seeing demyelinating diseases in Asia a lot, some of them will be affecting the other cranial nerves, and one has to look out for some MRI changes. I'm not very familiar with that. If it is one of these demyelinating diseases, then the treatment is totally different. Yeah. Other than that, that's about the type of cases that I have seen in my short career. Okay, thanks.
Thank you, Dr. Matthew. So he's the neurosurgeon in the group, so good to see his view. So can I invite Dr. Guru here? Guru, are you there?
Yes, sir, I'm here.
Yes. So most of the panelists seems to agree that it's trigeminal. So in terms of conservative management, in terms of medication for trigeminal, how would you go about it? So we have done the basic workup, we have done the blood test, we have done the MRI.
Okay.
The MRI, I think in this case is normal. So there is no compression of the cerebellar blood vessels in the trigeminal root entry zone.
Okay.
How would he go about treating these patients conservatively? What medication, what dose, what are his options?
Okay, hope so. The patient is of moderately built. I didn't go through the case. So if the patient is moderately built, I will be starting with either carbamazepine or oxcarbazepine. My option always goes for oxcarbazepine. So I will be starting with 150 milligram BD. For by 1 week, I will be starting with that. Then I will ask the patient if the patient is comfortable enough and still the pain is still more. Then I will increase the night dose by 150 more. So I will be going maximum up to 600 milligram. So mostly after 2 weeks, if the patient is still not comfortable, then I will be adding pregabalin.
Go on, go on.
Okay, so I will be adding pregabalin. So we will be starting with 75 milligram. So most of those patients, if they are responding, we will try to maintain with those drugs. Again, we will start titrating the pregabalin. So if not, then I will be adding nortriptyline. So mostly I will go up to 3 drugs. So I am not a good lover of baclofen. So I will maximum go up to 3 drugs. If the patient is not responding, then I will think about intervention.
Right. So this patient with Javad is presented is on oxcarbazine, total dose of 1100 milligram per day, gabapentin 1200 milligram per day, pregabalin 300 milligram per day.
Okay. So the thing is, I think oxcarbazepine has been overloaded for this patient. I think 1100 is not the recommended dose for any trigeminal neuralgia. I think maximum 600 milligram. So
Right.
again, I won't go with this gabapentin and pregabalin both combined. Doesn't mean you can divide the dose between this gabapentin and pregabalin. There is no use of putting both the drugs together. So either I think the patient has been fully loaded with all those extra drugs. I think now the patient is not a candidate for any conservative.
Oh, this is probably not the medication that Javad did. Maybe the previous physician may have done that.
Yeah, that's why it has been referred to Javad.
Right. Thank you, Dr. Guru. There have been reports where there are a group of people believe that trigeminal neuralgia is actually a type of myofascial pain. There are a lot of neurologists who like to do trigger point injection, especially intraorally inside the cheek. Can I invite Dr. Matthew Tong and ask him, is there a role for doing trigger point injections inside the cheek for trigeminal neuralgia? If so, in which patients would he do that?
I don't have experience, but I'll tell you of a story. I did a trigeminal microvascular decompression sometime beginning of this year where the patient's result was no good. So after that, for about 3 months, he was in pain. He even developed toxicity from the Tegretol, requiring admission with jaundice, etc. And then I tried to use some lignocaine gel in the mouth where he had a pain. And during that time, it helped him. It helped him at least able to take orally. But after some time, he gave everything up. He got over his liver failure, and he's now not on any drugs. And he says that he's okay now. So I think that is something like what you are saying, a trigger point injection inside the cheek. He was applying the lignocaine to his cheek, and it helped him swallow some liquids. Thanks.
Right. Thank you. Can I go back to Dr. Javed and ask him, considering this amount of oral medication, for the sake of the juniors, whenever you put these patients on this amount of medication, what would you monitor when these patients on this dose of anti-neuropathic pain medication? Dr. Javed.
Yes. So when the patients are on such a high dose of the medications, Then one most important thing what we need to see is before starting the medications, whether routine investigations have been done, complete blood count, and including the hemoglobin, the RBC count, differential count, and neutrophils, and etc. And along with that, we need to see if the patient is exhibiting any side effects because of these agents. Since there is a combination of the medications, most of the patients experience side effects like excessive drowsiness, etc.
Right. So your patient is a 51-year-old lady, right?
Yes, sir.
And this is it's a stiff dose of medication, but she's tolerating it because she has so much pain.
Yes, sir.
Right. Can I go back? Thanks, Javed. Can I go back to, so essentially what Javed is saying is he will look out for, he will check total count and differential count at a period of every 3 months when patients are on carbamazepine. He is looking for things like aplastic anemia, thrombocytopenia, because long time
Karthik, I used to add liver function test as well. Liver function test, and sometimes occasionally the electrolytes. Electrolyte imbalance also can be a side effects. Same way the liver function test, liver enzymes can also be elevated in some cases.
Right. Fantastic. So
What to add to LFT, and you have to monitor LFTs, especially if you have patients on carbamazepine.
Right. So the panelists are suggesting that all patients every 3 months should undergo total count, differential count, LFT, and serum electrolytes, especially when they are on such a stiff dose. Can I go back to Dr. Jayshree and ask, in terms of pharmacology, what other options we have? Medication.
See, these, I have found that some of the patients who are not able, with carbamazepine, it's very obvious, like everybody has discussed, it can cause side effects, and you have to monitor liver function. So the other options these days that we have on the cheaper side would be gabapentin. You can try Lyrica. The other medications include Lamictal or lamotrigine is another one that you can give. But again, lamotrigine, you have to be very careful. You have to monitor the patients. There can be side effects, fall in white blood cell count, etc. Valproic acid, people used to use a lot, but not anymore, not that much that I see. And if the patient is unable to sleep, or they could still have these lancinating pain at night, you might have to think in terms of either adding amitriptyline, or if the patient is very elderly, you don't want to increase their heart rate, trazodone or doxepin is another option to help them sleep. So of course, if you have methadone available and you don't want to go through something else, and you feel that the patient's having severe pain, not responding to intervention, you can try a low dose methadone like 5 milligram twice or thrice a day, but be careful not to combine too many things. You have to monitor your patients. You have to start with 5 milligram twice a day, see them every week. Close monitoring is very important when you add something like methadone.
Somebody in the audience would like to know the role of SNRIs or duloxetins.
Duloxetin, like, with any other neuropathic pain, duloxetine does have a role, but whether for trigeminal neuralgia, duloxetine alone will work. I have never tried just duloxetine alone, because age-old, it has been established that carbamazepine works, and so does something like Lyrica or gabapentin. Those are my first line. But many times these patients have been to several doctors. They don't come to me as a first person. So many times you will see that the patient's already taking duloxetine 60 milligrams once or twice a day. So what I would do is I would not change everything in the beginning. I would get a better handle of the patient, then slowly eliminate the ones that work or do not work. But patient may be taking duloxetine for either bipolar disorder or depression, in which case I would just leave that alone. Have I started duloxetine as a first line of treatment for trigeminal neuralgia? The answer is no.
Right. Thank you, ma'am. Can I go back to Javed and ask him? So you have a situation where your conservative management with medication has not given sufficient relief. This patient is 51 years old who's not adequately responded to conservative management. For the sake of the juniors, what is the algorithm for treatment of trigeminal neuralgia? If the conservative management has not worked, depending on whether they have neurovascular compression or not, can he elaborate on the algorithm for the sake of the juniors?
Yes, sir. So, if in case the patient is not responding for the conservative management, then the other treatment options which can be thought of are first is radiofrequency ablation of the Gasserian ganglion, especially if the third branch of trigeminal nerve, that is a mandibular branch, since it is involved over here. So radiofrequency ablation can be thought of as one of the option. And the other thing is, if the other branches, especially V1 has been involved, then balloon compression can be thought of as one of the options, sir. And if there is any, if it is any young patient who is having a vascular loop, then microvascular decompression could be thought as one of the options, sir, for treatment. And other options are like glycerol rhizolysis. That can also be thought, sir. That is retrogasserian glycerol rhizolysis.
Right. So the algorithm is that if they respond to oral medication, the patient stays with oral medication. If they don't respond to oral medication, you have two categories. One category is patients who have neurovascular compression. One category who don't have neurovascular compression in the MRI. So among the category where they are not responding to medication and who have neurovascular compression, you basically have to divide them at a cutoff age of anywhere between 40 to 50 years. So anybody with a neurovascular compression, not responding to oral medication, less than 50 years, these are good candidates for surgical decompression, which could be a microvascular decompression or an endoscopic microvascular decompression. So two options are there in terms of surgery. So this surgery is for patients who don't respond adequately, who have documented neurovascular compression, and who are younger, because the surgery comes with its own mortality and morbidity. So in patients with neurovascular compression beyond the age of 50 years, again, there are options are mainly pain interventions. The advantage with pain interventions is they are safer procedures, they are daycare procedures, much easier to be done. The disadvantage with pain interventions is the duration of relief is anywhere between 2 to 3 or 4 years. So you have to keep that in mind. If you were to do RF ablations in younger patients, you can't keep repeating them every 3 years because it will take a long time to keep getting treated. Patients who don't have neurovascular compression, the only option is to do one of the interventions that Dr. Javed talked about. So that's the way to algorithmically divide the treatment. Can I call on Dr. Guru here and ask him, would he straight away go for an RF ablation in this patient, or would he like to do a diagnostic injection, or how would he do it, Dr. Guru?
In this case, I like to go directly for RF ablation. That is, it's like a textbook case. So it's a clear cut. If the MRI is not showing because of it's a primary trigeminal neuralgia, then we can directly go for RF ablation.
Right. Okay. And can you describe your normal way of doing the RF ablation, Dr. Guru, just for the sake of the juniors? What needle, what position, how much temperature, quickly?
Okay. Okay. So So we have to go by submental approach. So the needle we'll be using will be 22 gauge 5 millimeter curved RF needle, that is 10 centimeter needle. So we have to focus on the lateral side. So I'll be starting the foramen is starting
So
slightly.
Guru,
Yes, sir.
CRM, ultrasound or CT?
It's a CM, sir.
Okay.
So I feel CM is better, not the ultrasound. Ultrasound not an option at all. So CM will be the better. So CT scan, I don't have that much experience, but still we can do better with CM. So we have to target the mandibular division of trigeminal ganglion. So once we reach that, once we cross that petrous spot of temporal bone, the lateral view, go for sensory and motor stimulation. So we can expect the sensory stimulation within 0.3. That means you are exactly near the trigeminal, that mandibular ganglion part of ganglion. Then go for motor. It should be at least twice. For example, if you are getting sensory stimulation with 0.2, the motor stimulation we are supposed to get it in 0.4. That is called sensory motor dissociation. If you are able to do with this, then the advantage is the patient don't have that much motor weakness after the procedure. Then I'll be injecting local. Most of the time, when we enter the foramen oval, the most of the time the patient will be jumping on the cord. So we have to be very careful. We have to give short sedation. Then we have to make the patient conscious, check their level. Then I will give 0.5 ml of local anesthetic. Then I will go for conventional radiofrequency ablation. I start with 60 degree for 90 seconds, one cycle. Then I will go for 65 degree. Then I will go for 70 degree. Totally, I will go for 3 cycles. So then once I take off, I have a thing learned from Dasar. I just come out of the foramen and inject some dexamethasone and come out.
Right. And what sedation do you use? Do you do the local anesthesia? You use propofol? How does it go, Dr. Guru?
So most of the time when the patient is comfortable till the stimulation, there is no need for any sedation. So I never give any preemptive sedation for these patients. So mostly I will keep the patients awake, so that sometimes what happens if we give preemptive sedation with the midazolam and fentanyl, sometimes they will become more agitated during a procedure. So I'll keep the patients comfortable. So once the patient is, most of the patients tolerate this procedure even up to the stimulation. So if the patient has some issues while needling, then I will give you a short dose of propofol. I will try to get the needle inside, get it inside, then I will get the patient back. Then once the stimulation is done, then I will give local and go off. So mostly I am not giving any fentanyl or midazolam as a preemptive for these cases. Though it is given in textbooks, I had some experiences, patients became slightly agitated during the procedure.
Yeah, I think the anesthesia depends on which type of center you are working in. So again, it's possible that you are able to manage it with local anesthesia itself, but most of the time, from whatever I have done, very difficult to do this in local anesthesia. You will require some sort of sedation, fentanyls or propofols or something. You very difficult to do this only under local, but that's fine. It depends on which center you are using, right? Can I go to Dr. Joshri and ask her, in terms of doing the trigeminal RF, is there any take-home points or is there any tricks of the trade? And what would she keep in mind when she does the RF ablation?
Only thing that I would do differently compared to what Guru said would be, the stimulation is very important. Usually, like Guru was saying, I would give minimal sedation for these patients. Usually 1 or 2 cc's of Versed beforehand. You have to use a roll under their shoulder. You have to get them comfortable. But it is good to have someone monitoring the patient, because sometimes either if they move their arm or they want to touch their eye, you really need to have these patients monitored. You may need 1 or 2 cc's of propofol, not a whole lot, but depends on where you are doing. I would do usually 2 lesions, and I pick between 65 and 70 degrees. I don't start with 60 typically. And I do inject local anesthetic and like half a cc local anesthetic mixed with dexamethasone, like Gautam would do at the end. Is there anything else? Usually before you inject your local anesthetic, make sure you have 2 to 3 views of where your needle is. If need be, put a drop of contrast. Make sure, sometimes, you know, you may think your needle is in position, but you want to be sure that you are not aspirating any CSF. That's only the word of caution. So, you know, after you give your half a cc local anesthetic before you do your RF, make sure, you know, the patient's able to respond to you for a minute or two before you go ahead and start the RF. That's all I would say.
And normally for the procedure that you described now, normally on an average, how much duration of relief do you expect now?
It varies again from patient to patient. You know, usually you would do one of these lesioning. Some patients have a considerable relief, like 40–50% at least, for about 6 months to 9 months. Okay. But then you have patients, maybe, you know, you have missed a twig, maybe you just lesioned one branch, because as you are lesioning, you are not seeing where you exactly your needle is. So sometimes patients do come back and say, you know, this pain, maybe there were 2 twigs involved. They will say, this pain is gone, but I still have some here, pointing to their face, or they may say, I have some pain here. Sometimes, you know, if it is just like the supraorbital region or something superficial, you can do like a local nerve block and see if that takes it away. But your guess is as good as mine. Majority of them do well, but you can have patients who will still have a remnant or a part of the pain that is still there.
Right. Considering this is only
Karthik, can I
Yeah.
comment a little bit on the local anesthetic and the sedation?
Yes,
I can
sir,
share
please.
some of my experience there. So first of all, you know, what Guru told, I also agree that in some patients, not always, that little bit of local anesthetic like, you know, fentanyl or midazolam, you know, makes the patients, you know, not obeying the verbal comments. They start moving. It can happen. So I also do not prefer the sedations much. If at all needed, I give propofol rather than giving total knocking down the patient rather than giving the small sedations. This is one of my experience. And second thing I'll be telling you regarding the local anesthetic. So I came across around 2-3 cases where even with the aspirations nothing came. I normally do not prefer dye. Dye is always mandatory when you are doing the balloon compression, but dye is optional when we are doing the RF radiofrequency. And here, what happened in this 2-3 cases, even the normal recommendation of the giving the local anesthetic injection is not more than 0.5 ml, not more than half cc. So even with that amount of the local anesthetic, and most likely it went into the CSF, immediately patient becomes apneic. So it happened, the 2 of my patients. So it must be done where we are having the full resuscitation. We must be having the facilities of the ventilation. Fortunately, in both the situations, because the local anesthetic dose was very small, so immediately after ventilation for the few minutes, 2-3 minutes, patients, again, came back with the spontaneous respirations. So this happened, 2-3 times. Another very important, the things what I have came across, that I have given a small amount of the local anesthetic, and still when I starting the radio frequency, patient is shouting in pain. That means, it can happen in some situations that normally, if you are remembering that when we are doing a conventional radio frequency, our listen is on the shaft of the exposed tip. But when you are giving the local anesthetic, sometimes if there is a facial seed, any structures, and local anesthetic might not be trickling back along the shaft. Local anesthetic might be going distal to the needle tip, so that the area where it is burning, where it is, a rise of the temperature, may not be adequately anesthetized. So I have again came to 3 such cases where I have given local anesthetic, 0.5 ml. When I started doing the RF, patient is shouting in pain. I have to stop it. Again the rotating the needle little bit, withdrawing a little bit, only a millimeter or 2, injecting the local anesthetic, and again I did it. So I came across 2-3 situations where even giving the local anesthetic, patient was not having the adequate pain relief before doing the procedure. So this is just my personal experience to share with all.
Right, sir. Thank you. I can see Dr. Pratibha Marshe in the audience. Dr. Pratibha, are you there? I can take the liberty to ask you a question.
Hello?
Yes, Dr. Pratibha. What would you do? Can I ask you a question?
Yeah, please.
What would you do if there is a CSF leak?
Yeah, if there is a CSF leak, the only thing is that you should not inject lignocaine, as sir was just now telling that we usually tend to give lignocaine before lesioning. But if you have aspiration, CSF in the aspiration, you should not inject lignocaine and you can go ahead with the lesioning.
So you're saying if there is a CSF leak, you would withdraw the needle from where CSF is leaking and then do a stimulation and then give sedation and do the lesioning. Is that what you're saying?
Yeah, that's what.
Right, fair enough. Can I ask Dr. Matthew Tong, comparing this procedure to the neurosurgical, the surgery, in terms of mortality and morbidity, how does the microvascular decompression compare to the pain injections? Dr. Matthew Tong.
Yeah, whenever we open the skull, therefore there is always the risk of mortality. The risk is small if we do it very carefully, very slowly. Nowadays, the risk profile of Asian patients in Singapore are so very low risk, so intolerant that we even say things like, if I see the petrosal vein preventing my access to the micro decompression, I will abandon the procedure. This makes the procedure really very iffy. Why are we doing something so big and then we see a vein blocking us and then we are withdrawing? So I'm becoming, and then when I see previously, before when I did more of these things, when I saw a vein, I just coagulated and went on with the operation. But nowadays I dare not do it. So I think that I'm very reluctant to do the surgery nowadays, and I would really advocate an interventional procedure in the first instance. That's my personal thinking. Thank you.
Right. Nice to get an endorsement from the neurosurgeon. Right. Okay. In terms of comparing different techniques, can I ask Dr. Das, glycerol versus RF ablation versus balloon compression, which would he do when? So you're muted, I think.
So I had an experience. I was actually working in one of the railway hospitals where there was no facilities of the radio frequency. And there I had an experience of using glycerol in many patients. So I will be telling, and if you are looking at the literature also, that if we are looking about the three important parameters, one is the sensory loss including the corneal, the sensation, loss of corneal sensation. That is one of the things which you don't like at all. So one is the sensory loss, one is motor loss. Motor means the muscles of the mastications, and third one is your recurrence. So there are three important parameters. And if you are comparing these three, the recurrence is maximum with the glycerol. The duration of the pain relief is somewhere between the 6 months to 1 year. But advantage of the glycerol is it is neither having that much of motor loss nor have that much of sensory loss. So it is safe in other ways, more safe than your the balloon or your radio frequency. But the two important disadvantage, one is your recurrence, and second important is when there is a recurrence, if you are giving it repeatedly, there is a fibrosis around the gastrin ganglion. So these are the two things why I don't prefer the glycerol as a choice. Except when the patient is having the first division involved. So first division, when it is involved, the automatic choice is either balloon compression or glycerol. Now the balloon compression is more invasive. It needs general anesthesia and it needs costly instruments. So if the patient cannot afford for the balloon compression, patient is having only first divisions, And in that situation, I might be still thinking of the glycerol. Otherwise, I don't prefer glycerol because of the early recurrences. Balloon, I'll suggest only for the first divisions, where the other divisions are not involved, because of the balloon has the advantage that the loss of sensation is minimal in balloon. But again, balloon has the disadvantage that the chances of the motor block is more compared to the other two options. So in that situation, the RF is having the moderate chances of the motor, and the sensory loss is higher. But if it is a second division and third division, the biggest advantage of the RF is you can specifically ablate the third or the second divisions. This option is not there with the balloon or in the glycerol. So in the balloon and the glycerol, you are going to ablate all the three divisions. But with the RF, we can specifically ablate the second division or the third division depending on which division is involved. So if the second and the third division is involved, automatic choice is the radio frequency. If the first division is involved, the first choice is balloon. If the patient cannot afford, then second choice is the glycerol. So this is the way how I used to go.
Right. Thank you. So yeah, so I think fairly technique-wise and this patient-wise, it's fairly straightforward. Trigeminal neuralgia involving V3 distribution, not responding to conservative management. Logically, the next option would be to consider an RF ablation involving the V3. So various experts have put in various inputs regarding how they would go about doing the V3 distribution. In terms of options, probably the last question, can I call in Dr. Jayashree and ask her, if this were to fail, would there be a role for something like a neurostimulation?
See, the trigeminal neurostimulators, I think I remember from many years ago, Dr. Henderson, now I think he's in Stanford, a neurosurgeon who used to work in Cleveland Clinic. He had a series like 6 to 8 trigeminal stimulators that he had put in. Of course, it is a neurosurgical procedure. At that time, we had mostly quad leads. We didn't even have the octrodes. So even with the quad leads, one of the commonest complications with trigeminal neurostimulators is the migration of the lead. And to get it exactly placed and to cover all of them was a problem. Now, with more discrete kind of contacts available, like a peripheral nerve stimulators, which people have started using not just in peripheral nerves, but against certain DRGs or certain nerves, it would remain, I would wait to see, whether they can be used in a case like this, where you can place it exactly against a mandibular or a maxillary division and see if you get better relief. But as far as I know, one of the commonest complications of placing a spinal cord stimulator or a nerve stimulator for trigeminal is migration of the lead. And it may go either way, but what I would like to say is, even if you think of doing a spinal cord stimulator for complicated trigeminal neuralgia, it should be your neurosurgical colleague who should be doing it.
Right. Thank you, ma'am. This again.
Can I add a little bit? Can I add not only neurostimulations, but other treatment options? Particularly, I will be telling about the two important situations in the trigeminal neuralgia. One situation is where you have done, and there is the anesthesia dolorosa or the deafferent session pain. I came across 2-3 situations in situation. And second, another situation is where the trigeminal neuralgia patient is very young. Again, one of the cases presented recently by Dr. Archana. Patient was only 18 years old and having no the vascular loop. So it is an idiopathic trigeminal neuralgia. And there, if you are repeatedly ablating the nerve, so definitely in some time, the patient might be having the deafferent session pain that is not advisable at that particular young age. So these situations, the one of the options, is the dry needling. And I tried in dry needling in these patients, and I got fantastic result. One of the reports already in our center center, Dr. Archana has presented it, and that we should not forget. And another option, treatment option, is the Botox injection. That is another option. Botox has also have some important evidences. So there are the two situations, two things, particularly in country like India, where the poor economic conditions, the dry needling can be a very good choice. And I will be telling that in these particular situations, when the patients cannot afford, when the patient is too young, so we can at least try one session of dry needling and see whether there is any good results. So dry needling, only one disadvantage of the dry needling is you should be repeated. One session is not enough. So that is one of the disadvantage. But still, because it is a very low cost treatment options, so we can have some more this kind of cases, and we can have some the good studies with a good number of cases also. So these are the two other things which must not forget.
I see more and more neurologists try Botox as one of the treatments. The only one of the main things that I have seen after Botox injection is sometimes, there is drooping of the eyelid or a entire facial palsy. So make sure that you use a low dose and know what you are doing. And yes, couple of times patients have come to me after the neurologist has done a Botox and, the face is drooping and patient has facial palsy. But Botox is an option. And I would totally agree with Gautam Das that dry needling is a fantastic option. If you have access to acupuncture, you can try acupuncture, but only one word of caution. Usually we do acupuncture with and without electricity. If you are doing the first session in trigeminal neuralgia, I won't add electricity to acupuncture the first sitting to just see how the patient responds. So in which case, where you are placing the needles, depending on the meridians versus dry needling, may be different, but pretty much it's the same. With acupuncture, as you put energy moving stimulation needles as well as localized needles. But I won't add electricity in the area the first session if I'm doing acupuncture.
Hello, can I add something?
Yes, madam.
Hello, yeah.
Yes.
I just wanted to say regarding this, sir was telling that poor people or low cost therapies. So I also would like to add that these peripheral nerve blocks equally work well in patients wherein you can't do trigeminal ganglion neurolysis, especially if it is an isolated division like ophthalmic division. So supraorbital, supratrochlear alcohol neurolysis does work for quite long time. Even infraorbital for the V2 division, if it is an isolated, I was shocked that I had a patient for 7 years, he had relief. So it's just beyond my imagination, but then I had to literally see his card and then I could trace that it was 7 years back that the neurolysis was done for V2 division, and he came back again with the pain. So I would also say that if it is not possible for you to do trigeminal ganglion RF, and if you don't have facilities, even these things in the initial days where you have started the practice, you don't have facilities and the patients are poor, then definitely you can go for these treatment options.
Right. Yeah. Peripheral nerves are good. That's taken. No problem in that. You can do peripheral nerve blocks. Only thing is 7-year relief for a peripheral nerve block means you must have pretty much done a very good block, or maybe you've damaged it or something. So, but yeah, 7 years is very ambitious.
He came back.
Right. Okay. And also there is a role for, which we have not discussed, there is a role for concentrated radiation, cyber knives, GABA knives. So there is a role for that as well. Anything else the panelists would like to contribute?
Can I add something?
Yes, sir.
I have came across perineural injection therapy with 5% dextrose, where people are injecting 5% dextrose under the skin over the affected area. And I have also done few cases of perineural injection therapy with 5% dextrose and got a very good pain relief. It is a very, very low cost and easy treatment, OPD-based treatment. Now, I have followed up 2 patients. I have given 3 sessions at a 1 month interval, perineural injection therapy, and now after 6 months, they are more than 70% pain relief is there now. So I think this is also one type of modality where RF is not available like that.
Right. Okay, sir. Thank you. Right. There are a lot of options. Yes, but again, we need more evidence for all of this. So probably my way of looking at these things would be the established ones are the percutaneous injection.
Right, Karthik. So we should be always promoting what is evidence based, but we should not be discouraging other things as well. What will be encouraging others, that if we are having other things which are giving encouraging results, we must be coming up with some publications on it, and we should try to make it evidenced. So that is what is needed. Otherwise, we should be the take home message for all the juniors should be, we should be following only those procedures which are recommended on the evidence-based medicines. And if you think something which is encouraging, we can plan for some studies.
Right. So yeah, this is fairly straightforward case. So nothing for me to sum up. Straightforward V3 distribution, not responding to medication. RF ablation is an option. We talked about technicalities of RF. We talked about various other options. RF ablation, glycerol injection, balloon compression, neurostimulation, radiosurgery, concentrated radiation. So we discussed about all of this. Obviously, Dr. Matthew Tong talked about microvascular surgery as well. So we discussed about all of these options. So probably I'm going to give you guys 2 minutes. If there is any doubts, put it up in the chat section immediately. I can see Dr. Ahmed Abdel Zahir wants to ask a doubt. Please put it up in the comment section. And quickly, can I ask Dr. Das to elaborate? It's a doubt from the audience. Quickly, can you describe how will you do balloon compression of the trigeminal?
So balloon compression is normally, we have to have some Fogarty's catheter. So around, either 12 or 14, and we'll be putting, going through the foramen ovale, almost similar kind of procedures. And we have to inflate the balloon and with the dye. Here we have to give the dye. And of course, before, inflating the balloon, it's a very painful procedure. So we have to give the general anesthesia and we keep it inflated for around 1 to 2 minutes and then deflate it again and take the whole things out. And compared to the other modalities of the gastrin ganglion neurolysis, this is the procedure which is much more invasive with a thicker gauge of the needle and the more painful procedures. So a little bit more invasive and more costly procedures than the other things. But otherwise, putting the needle through the foramen ovale is the basic thing, which is exactly the same steps what Guru described for the RF are exactly the same. There is no differences. Only thing is here we are putting larger gauge needles through which we are putting the catheter.
Right. Final question. What is the target for dry needling or Botox injections? Where would you do your dry needling?
So again, dry needling is, first of all, it is not an established therapy. So exactly the how to do the dry needling, the recommendations, definitely Loxiv has some papers and what I did in our center. So dry needling, what we did was we are mapping the painful area and we are using the 26 gauge hypodermic needle, which is not going too deep. And we are just putting into the subcutaneous areas at a distance between the two needles. Suppose we are making the area of the map. This is the painful area. We are first drawing the map of the painful area. And we are putting a distance between the one needle to the another, somewhere around, the 2 centimeter. And we are putting multiple needles. Normally in the one side, like here, what he has described, around, 6 to 8 needles might be enough for that. And we are keeping it for around 15 minutes, and then we are taking it out. So this is what we are doing. But there are a lot of ways to do the dry needling. Some takes the longer needle, some takes the acupuncture needle, and Dr. Jayashree was telling that in the difference between the acupuncture and the dry needling is in the acupuncture we are following the meridian, but in the dry needling we are not following any meridian. We are just making a map of the pain, and we are putting in that area at a distance of around 2 centimeters.
Right. So we had a very fruitful discussion. Thank you to Javed, and thank you to all the panelists for participating and giving your valuable inputs. I hope the delegates benefited from the discussion. So yes, so the case was managed effectively, and we discussed various options that are available. So thank you very much to all of you. We will continue the series of discussions. I think from Dharavia Pain Clinic, next would be the quiz activity, and then subsequently we will have.
Yes, Dr. Pratibha can announce the quiz of the next week. Pratibha, are you there?
Yeah, yes, sir, I'm there.
So can you please announce the next week,
so we
next
have
Saturday?
on 17th of October, and the topic for the quiz is back pain, but the lecture will be on spinal canal stenosis by Dr. Sudhir Diwan, and whole of the back pain that includes the SI joint, the facet, myofascial pain, and disc-related back pain, including spinal canal stenosis. All the topics will be covered in the quiz, and I'm sure that everybody is excited to go ahead with the next quiz.
So there are 12 teams participating, and our first match was very exciting, and we are also expecting a very exciting the second one next Saturday.
Yeah, so any of you who have not participated or you have not attended the quiz, I must say that you should come and attend the quiz, and you will find it, though you are not participating, even attending the quiz itself is very exciting. So I request all of you to join us for the quiz.
Good. So lots of activity happening from Dharavia Pain Clinic. So good to see. So next is the quiz. Subsequently, we'll have more panel discussions. Also, if anybody, one of the young juniors or any of the, younger pain physicians or juniors or anybody would like to present subsequent difficult pain case scenarios, you're welcome to do so. Send us a message or WhatsApp, and we will include you in the subsequent sessions as well. So I would like to congratulate and thank Dr. Javed. He just had to run and make another presentation, so he ran away. So he asked me permission and left. So thank you and good job, Javed. Thank you to all the panelists, Dr. Jayashree, Dr. Pratibha, Dr. Guru, Dr. Matthew Tong, Dr. Novi, Dr. Kausar, Dr. Gadir. So all of you who joined in today, thank you very much. Thanks to all the audience for coming in, and we will continue doing more programs. Thanks to Dr. Das and Dharavia Pain Clinic for running the show. Thank you very much.
Thank you, Karthik. You are moderating this session so nicely, so excellent way. All the people, you can tell that everybody is enjoying. We are moderating it fantastic way.
I agree with you, sir. He is doing an excellent job.
The first time
we have. Are there TV channels contacting you?
The first time we have actually seen Dr. Pratibha without her camera on, so it has to be something special. So thank you very much. Thank you, and stay safe, everybody. Thank you very much.
Thank you, sir.
Thank you. Thank you.
Thank you, Javed, for excellent presentation.
Yeah, Javed, well done.
Thank you so much. Thank you so much, ma'am. Thank you so much.
Javed is having the highest marks in the exam of fellowship in India.